Vinny, I think each and every one of us who's doing transcatheter work would be handicapped without his app, apart from being a brilliant surgeon and inventor of some of the new tech that we're all going to be using. Vinny, are you good to go?
I'm going to give a very quick talk on valve-in-valve. I think most of you are going to do it now or already have done it. And recently, last week, we had another webinar. So trying to keep this slightly different from if the patient comes to your office, you know, how you're going to say, yes, this is the thing I'm going to do or not going to do, or if I'm going to do, how to plan it and get a very good result. These are my conflict of interest. So this field is explosion in terms of exploding in terms of what we can do with TAVR devices. So aortic, of course, mitral can be divided further into valves, rings, and MAC, and of course pulmonic, which was already tried with pediatrics, and now tricuspid. So we're going to mainly focus on aortic valve-in-valve because of the time. So this is one of our first cases ever. This was in London, St. Thomas's. You can see 2010. Great, you know, third time re-op, beautiful procedure, no contrast, very quick recovery. So the question is, why not do this in every patient? Means every patient who has got a valve which is degenerated, why not just do TAVR at this point? And I think this is going to be something very similar to what Dr. Grube said. Is TAVI should kind of be the first option when you consider therapy. So when you do valve-in-valve, there are some important considerations. There are some common considerations like imaging, need of TE in specific cases, post-operatively in which patients you should use anticoagulation, and as I said, indication. But there are very important specific considerations. So if aortic, then stentless versus stent-led, a coronary obstruction becomes an issue, gradients become an issue. But if you are doing a mitral, you know, gradients become maybe less of an issue, but more becomes his LVOT obstruction and which approach you are going to do and how you're going to achieve a good position. For tricuspid, as you can see, you know, if you are going to use spacing, then how do you place your pacemaker? It's in the coronary sinus, left ventricle, how you're going to do that, or without pacing, maintaining wire position. So I think what I'm trying to say here is that one valve-in-valve is not similar to other valve-in-valve. So with this, I think the other layer of complication is which TAVR device you're going to use. Because as you know, we have got so many devices. And initially what happened is as new devices came in the market, everyone wanted to be the first one to use it in a valve-in-valve. So we had a lot of bad results to start with. And this is now pretty much refined now. So let's look at aortic valve-in-valve very quickly. So first important thing is all the TAVI devices can be used in valve-in-valve. So please choose your TAVR device correctly. Second thing is that transfemoral access is the most commonly used. So we are not going to discuss it anymore. And then the planning is the most important thing. And the reason to do good planning from start is these three things. One is bad positioning, high gradients, and coronary obstruction. So the way we look at it is when the patient comes to our clinic and we say, okay, sure, you know, this is for valve-in-valve, we first look at the details of previous surgery because that technically gives you good information on what was done. Say, for example, if a root enlargement has been done, then the surgical device is never in the right plane. It's always tilted. And I think that becomes a very important thing to consider when you're approaching it through a transfemoral angle. If a Bental has been done and an ascending aortic graft has been put, many times you see a kink in the graft in the lesser curvature, and that can prevent you from crossing easily. And then you're going to modify, you know, which wire you're going to use. Are you going to need a buddy balloon? Or sometimes can you use a taller device like Corval at all? And then you have to probably change your choice of the device as well, depending upon the anatomy. So we always look at that, and then essentially it's between the green square, which is a risk of reoperation, versus the orange square is the risk of complication with valve-in-valve, which kind of guide us into making a right decision. So this is technically my checklist. This is for all our fellows as well. You need to, you know, go through this pretty quickly in terms of, you know, what's valve, etc., to get a very good result. And I'm just going to walk you through it with one example. So first important thing is, of course, which surgical valve. As you know, unfortunately, in the aortic valve, we have got stented and stentless, and stentless is again divided into valve in valve, root replacement and subcoronary. And I'm going to show you some pictures to highlight the importance. Fortunately, all the stented devices look very different. So I think the most important thing is, if you don't have details of the patient, look at the X-ray, or look at the fluoro of the patient when he or she has undergone coronary angio, and you can then match this imprint with the image which is there in either publications or in the app, and then define what kind of device it is. For example, the top one is a perimount, which is made by Edwards. Then the next one is a porcine Carpentier SAV made by Edwards. The third one is a trifecta made by St. Jude, and the last one is a mosaic made by Medtronic. This is just going to, I'm just going to pick up an example. As you can see that you can find the information either in the op note, implant card, app, or record, or your fluoro. So let's take an example that this suppose is a mitral flow, and you have identified it from the implant card. So I think sometimes there is a bit of confusion, but I'm not going to highlight it just now between how the notes are written. But say this is a mitral flow, then you can see that this is a pericardial valve, and the leaflets are sutured outside the stent frame, as you can appreciate in the pictures. And more importantly is the marker, the fluoroscopic marker is in the sewing ring. Now, these three things are very, very relevant to your outcome, and these things are very important when you analyze risks such as gradients and coronary obstruction. Now, why do I say that? So this is how the implant looks like under fluoro. So I will take an example of a size. So let's say this patient has a 23 mitral flow. So what happens is that number 23 really doesn't mean anything. It's just a label size for surgeons. And this is where the initial confusion occurred when we started doing valve in valve. So this doesn't mean the inside diameter is 23. In fact, in mitral flow, a 23 size means the inside diameter is actually 19, which is called the true ID. And I'm going to explain you what it means. I'm just going to compare this with another example to highlight this point. So this is a perimount valve. Again, say this is a 23 size perimount valve. Now the inside ID, the true ID is 21. So that means label size and the true ID actually is not collaborative. So this is what I'm highlighting here, that different valves have different stent ID and different true ID. So what I mean by true ID is when the leaflets are mounted. If you remember, I just said that the mitral flow, which is on the extreme right side, is leaflets are pericardial and they're outside. And that what it means is the stent internal diameter doesn't reduce by any number. So if it is, say, 19, it remains 19. But in perimount, it will reduce by 1 millimeter. And if it's a pig valve, porcine valve, it will reduce by 2 millimeters. So this becomes very important, I think, when you're choosing a TAVR device of appropriate size, because you should not use the label size, but you should use the true ID. The more important thing, the next step is which TAVI valve you're going to use. As you know, let's take the same example now. This is the true ID of 19, and essentially you will be using a Sapien 320 or say Core valve 23. And I have put an asterisk on it because nowadays people tend to fracture the devices. So if you are going to fracture it, it's a borderline sizing. Then you may consider using a bigger size device like 23 Sapien 3 or 26 Core valve, provided that sinus width is good. Because what you don't want to do is fracture the device and actually push those leaflets which are outside towards the coronaries further, and then actually have a more life-threatening complication called coronary obstruction. In my opinion, at least, I think I will accept a higher gradient, but a alive patient, rather than having a coronary obstruction on table and then try and salvage it and have actually a bad outcome. So I think this example I've chosen is just to highlight that point. So the next thing is, of course, approach and risk of coronary obstruction. Approach is, of course, transfemoral most of the time. And again, this is what I meant was coronary obstruction risk. And you can appreciate very well from these three pictures that a pig valve with more delicate leaflets, and the leaflets are always shorter in height, have a less risk of coronary obstruction rather than a pericardial valve, which has got a wrap-up design outside and taller leaflets. But more importantly is how the sinuses are in relation to coronary ostia and the valve. Because if there are narrow sinuses, the risk is higher. And if there are wider sinuses, the risk is actually very, very low. This is just to show you an example of early days. You can see this was still a transapical approach. We have put in a mitral flow. Nothing has happened. That's because I can play this again. Is you can see that the coronaries are high and the sinuses are very wide. And that's the reason, despite the fact this is a mitral flow, coronary obstruction is not going to happen. Of course, you can measure all this very nicely on a CT scan, actually, and a virtual implant now, so that you don't have to take the risk like we did many, many years ago, where we had no CT scan at all. So Danny Davir and the group has really defined a very nice index for us called virtual, valve to coronary distance. And of course, you need to also see the strut orientation so that nothing is in front of the coronaries. And essentially, the VTC distance of less than 4 means you should be really cautious. If it is more than 7, that means it is a less risk. And between 4 and 7 is a gray zone. And you can say, for example, if it's a porcine valve, if you remember, the true ID goes down by 2 millimeters. This is where the distance you're going to measure, which is say between 4 and 7. But to be honest, the TAVR device is going to be further inside, so less risk. But if it's a mitral flow-like device, then the TAVR device is going to sit further outside in relation to the sinuses, and that's why the higher risk of coronary obstruction. So I think, again, you need to analyze that on your CAT scan. The next challenge during the procedure you do is making sure that your TAVR device is in a good position. Now, what is the ideal position? Ideal position is two. Is one, that it doesn't escape. That's more important. So it's fixed securely. Early days of valve in valve, the only thing we were worried about is embolization. But now you want to have best security, and at the same time, you want to have the least gradient when you're doing it. And I think this is the reason if you implant the device 4 or 5 millimeters below the sewing ring, you're going to get best of worlds. This is just to highlight, different valves have different reference markers. I'm not going to go into the details, but essentially you need to identify the sewing ring and then implant the device. This is again to highlight why it matters. This is, like, for example, a Evolutar in a Carpentier Edward porcine valve. You can see I have just drawn the leaflets. If you implant it 4 millimeters below the sewing ring, which you can see here, you can get the best hemodynamics. But if you implant it like this is how we did it in early days when we couldn't recapture. The valves now intra-annular and probably constricted, so you're not going to get the best result out of the same device. So I think this is very, very important. You pay attention when you implant these devices. For SAPIEN 3 as well, it's very important because these valves both, they shorten in a very differential way because the bottom cells are smaller than the tall cells. So if, for example, you're using the size 23 for a true ID of 19 and true ID of 22, is going to shorten differently and expand fully or incompletely. So again, you need to adjust with your experience the deployment height of these devices. And the way we do it now is actually we pay attention to the top of the device rather than the bottom. So because we know that the top doesn't shrink that much compared to the bottom, and then get it right. One word of caution is about mosaic. Mosaic is a valve which has tricked many people. This is not the reference line. Actually, the reference line is at the bottom. So if you are going to use the TAVR device for mosaic, just be cautious and of course refer to the guidance which is already available for this. Very quickly, people get confused at present between what is balloon and what is fracture. So we selectively use BAV in valve, which is not fracture, just BAV. And one of the best indications in my mind, and I would like, Eberhard, Susheel, and Ganesh's thought on it as well, is stenotic valves, especially pericardial valves. Because if you remember the structure of mitral flow and perimount, these pericardial valves are like a volcano when they actually stenose. And what happens is, even if sometimes you have crossed it, it's impossible to cross with the device. So what you can do is a soft BAV just to open up the device. And those of you remember 2 or 3 years ago, Dr. Webb, who is so experienced, took all 45 minutes to just cross the valve and had to do it off camera. So I think what I learned from that is doing a soft BAV is important. You can also, see coronary obstruction risk. You can also find out, the sewing ring where it is by using the waist of the, balloon, and that's very important in some cases. Uh, I'm not going to talk on valve fracture. It's a separate topic, maybe for next webinar or the one after. But this is just to show you, in Colombia, we just did a video to highlight that when it fractures, it opens up to a point. There is a lot of confusion at present between should we do it before, should we do it after, what valve one should use. But there's only one important thing, is if you're going to do a valve fracture, make sure that your TAVR device is a bit deeper than you would implant, because when you fracture, the diameter goes up and the device is going to shrink further in the height. So if you're using, for example, Portico, Evolutar especially, I think you should fracture it, but deploy it slightly lower. Just 2 or 3 slides on stentless valves. One thing about it is they are not visible under fluoroscopy at all. The anchoring may be poor, and more important is that the coronary obstruction risk is higher. There are 2 techniques of doing it, or 3 techniques, but essentially I'm just going to highlight the 2. One is the root replacement, where you can see the surgeons have reimplanted the coronaries. Usually we tend to implant the coronary slightly higher up, so the risk is definitely lower. But there is a second way of implanting, mainly commonly practiced in India as well, when homographs are used, is subcoronary implant, and you can see that the suture line is extremely close to the coronary, so it can, obstruct. This is again to highlight in a pictorial way the same. And very importantly, what I just want to show you is use certain tricks. Like for example, here we have put a pigtail. We are constantly injecting, a contrast to identify the annulus as well as the coronary artery. So I think it's very important in stentless valve. Make sure that these 4 or 5 points are addressed before you do it. And 2 important points I would say is analyze the CT scan like a native valve. And the second important point is, I think, pay attention to coronary ostia. So I think I will stop at this point, Sai, this talk. And if there are any questions, then I'm happy to take.
Dr. Bapat, as usual, Vinny, we can just keep listening to you for another ever. That was so informative. It was so information packed. I just want to take a quick minute here. There have been a few questions from the audience. I'm going to quickly just throw these questions out, and then maybe the rest of the panelists can come in and say something. But before I get to questions, I want to thank some of our international participants. Dr. Soas, Dr. Alzate are here from Philippines, Dr. Tay from Singapore. Of course, we know from Indonesia, and thank you all. It's so refreshing to see all of you here. Thank you for joining. And a few quick questions. Ahmed wants to know about the silica procedure, but Ahmed, that's a complete different discussion topic, and we'll make sure that in our next agenda we'll include it. Dr. Parminder, for fracture for valve-in-valve, again, like Vinny said, that's too big to cover in this, but we will definitely make sure we keep that in mind. Rajan, you wanted to know about role of CT in planning TAV. The simplest way I can explain the importance of CT in planning TAVI is that if you walk into a room with a small night lamp on, that's all the other information you've gathered, and then you throw floodlights in the room and that's your CT. It is the mainstay of your TAVI planning. And with that, I'm going to let Ganesh step in and just give his thoughts on this, and then go ahead and give his comments on Vinny's talk, and then we can move on.
Hello, Vinny. As always, you don't really need to go follow on Vinny because he normally summarizes things really, really clearly and succinctly. And I guess the couple of points, valve in valve, it's a different kettle of fish compared to a standard TAVI and a native valve. Your assessment of the surgical procedure is very, very important. The surgeons it's really important for you to pull up your own notes and see what difficulty the surgeons had. Did they had to implant it slightly differently from what the valve is designed to do? It's equally important, I think, in terms of selecting your valve that you're going to use for the TAV. My personal view is if your surgical valve is 25 and less, I think using a supraannular valve will give you a result with less gradients. Any valve that's bigger than that, you can pick any of these valves. They tend to all give really good outcomes. I think the outcomes with valve in valve has significantly changed from the time we've had resheathable technologies, where we can position it, redeploy it. The risk of the valve moving is a lot less. I've now increasingly started using control pacing during deployment, especially if the valve is not stenotic, where there's very little to hold the valve in position. And finally, in terms of pre-dilatation, I must say I tend to not pre-dilate routinely, but aggressively post-dilate more often than you need to. But be aware that whenever you're post-dilating, as Vinny has already mentioned, it's not necessary to fracture, but it's to optimize the gradients across the valve. And if you get even the slightest gradient in a valve in valve invasively, post-procedure on the echo, for those who don't routinely do echoes, during procedure, it will definitely be in the high range. So if you find even a slight gradient invasively, then please do post-dilate, but make sure you do rapid pacing aggressively to significantly dump the pressure, because your risk of avulsing the valve during post-dilatation is also higher. Thank you.
Thanks so much, Ganesh.
Yeah, no, Vinny, someone raised the issue, and maybe just for a final comment on this, they said surgical valves should be designed with TAVI in mind. There's the Inspirus valve from Edwards, which is an expandable frame. Are surgeons thinking differently when they do surgery now with the idea that it's going to be valve in valve, and how are you approaching things differently when you do surgery?
I think it's a very, very important question, Susheel. And as you know, that my generation of surgeons definitely have embraced the idea that we want to make sure that this is a TAVR friendly, or as I coined the term many years ago called TAVR proof procedures. So for example, the Medtronic made another pericardial valve called Evolus. So it's a shorter in height, for example. So it reduces the risk of coronary obstruction by just that simple design. There are other things which we do. For example, if I do a root replacement now with a freestyle root, I tend to put some radiopaque markers outside on the suture line so that they become clearly visible under fluoroscopy later. And some of the old-time surgeons I worked with, in old days, what we used to do is there was a metal ring around the coronary arteries, which I'm sure you all must have seen many times when you do a repeat angiography. So in root replacements, I tend to mark my coronary reimplants as well. So I think that's from the surgical side. On the mitral side as well, it's the same thing. If we use a rigid ring, it's not going to be TAVR friendly. If we use a semi-rigid ring, it's going to be TAVR friendly. So there's a lot of effort going on from the industry as well to adapt to this patient continuum or lifetime management. And I think from surgeons as well, I think there is an effort now, as we saw in Partner 3, that majority, the label size implanted was much higher than what we saw in Partner 2 and Partner 1. So there is an effort now to use CT scans even for sizing as we do it in Colombia, and then make sure that we are implanting a good size valve, especially in young patients, if they opt for a biprosthetic valve.
Dr. Grube, you want to pitch in?
Yeah, as always, I listen very carefully to what Vinny has to say. And I don't want to really dilute the information that he gave, because it was packed in 12 minutes or 13 minutes. A lot of not only objective information, but also filled with personal information. which is very, very important to think about once you move into the valve-in-valve situation. What I do have to say though is, and I don't want to dilute anything that Vinny said because it was masterfully done. The problem of pre-dilatation or passing the stenotic valve, degenerated valve, is a problem that before John Webb did this live, I tried to do the same thing live at gyms years ago, many years ago, not understanding the tenting of the stenosed valve, or what you call the volcano. That is a huge problem, what normally you don't pay attention to, but you have to. And under these circumstances, it is important that you take that into consideration, that the stenosed degenerated surgical valve is different from the native stenotic valve. And it takes time, it takes some tricks to get through this, but this is something that you shouldn't be underestimating. Everything else, I have to say, everything that he said is wonderful. And even we as experienced operators can still learn from Vinny's surgical interventional experience. So thanks, Vinny, very much.
I must comment that Eberhard, your case of crossing that core valve was, that's the first time I saw you, and I was thinking cardiologists are just crazy. And I must say that case, that was my first time I was ever exposed, because thanks to Martin Thomas, I was like, what is he doing? And Martin said only Eberhard can do this thing.
I remember that, Vinny. I remember that. But it was traumatic.
Susheel, Ajit Desai has got a couple of questions. Dr. Ajit Desai is a couple of questions. Can you see them, Susheel? You want to pick them up for me and then start your talk?
Sure. It says, the one question I do see is, what type of BAV would you recommend? I'm not sure if he means bicuspid aortic valve, because he said surgery versus TAVR. We can, I think I'm going to save that if that's regarding bicuspid, because I think Ganesh is going to talk about.
Pick it up. Okay. Maybe Dr. Desai, you can just explain what exactly you wanted, and then Susheel, floor is yours.
Okay. And then the other question that he asked, which I think is an important one, and Vinny sort of addressed it, is in what type of valve would you use SAPIEN 3 or MyValve, balloon expandable versus core valve? And I think the issue of hemodynamics is an important one, and expectations and understanding. And I think we're learning more and more all along. We've seen that if you get a mean grain of 20 after a valve-in-valve, the outcomes are poor. So if you have a 21 millimeter CE valve, doing a balloon expandable, unless you're willing to fracture, is not going to give a good result. And doing self-expanding in those scenarios, especially in a stenotic valve, is going to clearly be the preferred option. If you have a 25 or a 27 valve, then balloon expandable, you'd get a good hemodynamic result. So I think it's all about expectations.
Right. There is one caveat. Eberhard, for some reason or other, surgeon has chosen to put a bioprosthesis and is a comparatively young person, for the reasons that there are the issues of anticoagulants or whatnot, and he has decided that I would prefer to put a bioprosthesis. In that situation, don't you think that the TAVR will have an edge over bioprosthesis in terms of repeat procedure over a period of time down the line in 10, 12, 13, 14 years, whatever it may be? And we know very well that bicuspid patients are comparatively younger.
Right. Obviously I can answer that question. I would like to hear Vinny's opinion about that, but I agree with you. The provision and what I would like to say to the surgeon today, that now with a competing technology as TAVR is, he has to be a little bit more selective in what he does and a little bit more careful of what he does. He just cannot say, okay, I'm going to put a valve in because I think it's a good valve. He has to look into the future, and exactly what you're saying. If he puts in a bioprosthetic valve, which most of the surgeons in these days do, knowing that the most important part on the long term is degeneration, will handle that with a TAVR. That's why probably the whole thing swings to implanting bioprosthetic valves. The problem with that is, if you're not really careful and you implant a smaller valve, as we all know, opening areas in a bioprosthetic valve is too small, then on a follow-up with a TAVR, we might have a too small of an opening area, then we have to get into fractures and all of that. So if the surgeon is doing a good job with a bioprosthetic valve, I would still go for them, particularly in the bicuspid. But I do agree that, and you're right, TAVR might actually be a good option with a good size valve, and then go in with surgery as a second one. I agree with that.
I think just to add on to another layer of complexity, first of all, surgeons never choose a valve. It's always the patient. So most patients want a bioprosthetic valve. And I think Susheel can relate to our conversation a week ago about this very active patient who is really big, but he likes skiing and all, and he wants a bioprosthetic valve. And his BSA is such, and I actually pushed in that patient for TAVI, or if a surgery is done, then only something like a freestyle root replacement, because I think that's very important. Second thing is, in young patients, valves are not going to last for 10, 12, 15 years, because we know that in younger patients, they do degenerate faster. And I think it's very important what Dr. Mehta pointed out is, the thinking is changing. Can we actually do a TAVR? And then, as I said, just one surgery lifetime if needed. And I completely agree.
Dr. Bapat, I think one of your devices is interfering.
It's not mine.
Guys, can you just, admin, mute everyone?
I will unmute myself. So I think I'm just adding some discussion, which is over, say, 3 years in Colombia now, we always do. And I think this is very important point is, can we offer TAVR in a good anatomy? And as Eberhard pointed out, that a good anatomy is going to be very important. And then do either a TAVR in TAVR or one-time surgery. And I think, in my opinion, if you ask me, that's the way forward. But we just have to wait for another 5 or 6 years to understand the durability and how TAVR in TAVR works and how TAVR explants work. One very quick caution is, we all discuss TAVR, implanting TAVR, but we forget the most important thing, that the functioning element of the TAVR is the leaflets. And I can tell you that every leaflet is not going to work same. We know that, again, I'm highlighting things again. I sound like a broken record, that from surgery, we learned the same thing. One valve's not same as the other. So I think just be cautious, and I think modify your practice depending upon not just your skill level and everything, but also what is available to you.
Perfect.
So raised all very important points, and I think the key is conversation, not amongst just the physicians, the surgeons, and the interventionalists, and the general cardiologists, but also with the patient and expectations. And I think as long as you have those conversations regarding expectations and everything, I think that's the most important thing. There's no one right answer for every patient, but the conversation needs to happen. I think the concern always is, if the heart team starts to break apart, it's not that the heart team is needed for the procedure. The heart team is there to ensure that the conversation occurs. And I think for me, that's the most important thing. Vinny and I will argue. In the end, we may disagree, but the conversation occurs. Patient hears it, and the choices are made. And patient down the road understands consequences of choices.
Well, I have to admit, Susheel, sorry, that I see a little bit differently. I see this a little bit differently. First of all, I didn't know that actually the patient is choosing the valve. That is completely new to me, at least in Germany. It's still the surgeon that is eventually, because the patient listens to the surgeon or to the cardiologist of his choice. Do you discuss a core valve, a Lotus, a Accurate, a whatever valve No, you make a suggestion because what you think is best for the patient, and usually the patient follows your advice. It's not the other way around. There might be patients that come, no, I want to have a sapien because of this or that, or my friend has it and he feels good, whatever the reasons are. But at the end of the day, at least in my experience, the patients follow the physician's advice. The second is, if you disagree in front of a patient, that is about the worst scenario that I can think of. I might have misunderstood Susheel here.
Oh, no, this is not in front of the patient. No, these are our conversations.
I think what Susheel was, I'm going to pitch in. I think what Susheel was trying to say is that they argue, but when they go to the patient, they go with a cohesive answer and cohesive choices.
We go, and Eberhard, I think I want to correct you here that what I meant was, Dr. A.B. Mehta's question was very relevant, is the surgeons don't mean, I think we don't advise generally is very strongly of say mechanical versus bioprosthesis. That's what I meant. And I think it's become very important. I can tell you that in England, no patient wanted a mechanical valve. In US, actually, it's very different because we still have good conversation, especially in some patients where we strongly feel they should have a mechanical valve. And I think that's very, very important. And Dr. Mehta's question was very relevant because if we are implanting a bioprosthetic valve at age of 55, in my opinion, we should just do a TAVR. Because why are we doing a bioprosthetic valve, which is of small size? And, you know, I may not be liked by many surgeons when I say this, but I'm thinking more of the patient. So, but
you're loved by everybody.
Yes, that evolution is happening.